The idea was now to get it more towards an interactive next part. So, Shawna, come up front, please.
All right, so I've been taking copious notes, and I take it by...
Notes of the Dutch presentation.
Yes, yes, and I take it by your laughter that you understood it as well as I did. So go ahead and have a seat. So one of the things that, and Karen, I hope you're going to just hang in here and join us. One of the conversations that we wanted to have is looking at the economics and the imperatives.
Yes.
So economics is pretty easy to understand. How much are we spending for the outcomes that we're getting? And to your point about no system has it perfect. So I have a really interesting vantage point. When I first started as a clinical care, I was in critical care specialties. And I had this wonderful job that allowed me to go do international medical repatriation. So what that meant is there would be a patient somewhere who was having some really bad situation, and I would be a nurse called in to fly and go pick them up and move them from one place, stabilize them and move them from one place to the other. And what was so fascinating about it is that I got to see care rendered in all parts of the world. And it wasn't just at that macro level. It was right there at the bedside.
Is it called Eurocross or similar kind of thing?
Europe Assist is the company that I started working with. I was based in D.C., and so it was interesting that the vast majority of people that I was transporting, they were in a place far away from home, something bad had happened, and really it was, I mean, the patient wanted to get home because we all do better when we're in our own homes. The economic imperative was most of the countries, they pay for that health care, and they want those dollars in their own economy. They don't want them somewhere else, and particularly if it's in the United States. I mean, and I'm not joking about that. They really do not want it there. They want it to stay in their own economy. So when we're talking about the economic imperatives, there's that thing of what is in the best interest of a country to do from the standpoint of looking at the disease burden. And then there's the imperative that says, as decent human beings, what is the right thing to do? And where do we find the nexus point of those two, oftentimes at cross purposes? And I thought what we would where we would take this is look at the cradle to grave approach. So we have everything from the beginning of life to the end of life care. And I think both of those extremes offer us challenging questions, important situations that we need to address. So as a statistic right now, and I don't know how many of you follow the OECD and looking at healthcare outcomes where they chart how much do countries spend and what are the outcomes that they're getting. And they'll look at life-adjusted years in quality, length and longevity, birth and infant mortality, so maternal during birth, the perinatal experience. And what we're seeing, interestingly enough, is that we're seeing an improvement in that, where there are fewer babies that are dying at birth, fewer mothers, with the exception, surprisingly, of the United States. And where there had been a leader, that is no longer the case. And there are many reasons why. I mean, we can go through all that, but let's start with the Dutch system. Let's talk about what are the areas that you're focused on? What are the imperatives, and what are the economics at the beginning of life?
Well, first of all, the 10 years back, we didn't have very good childbirth rates either in the Netherlands. So we want to have the cooperation between the professionals should improve. But there's a lot of focus in improving the first 100 days in a child's life, because we think if there's a good start, there's a better chance of a good life. And I think it's really important. And there's not really an economic talk, but it's really about everybody has a right, and a good start. It's really about solidarity. But there's also talk about freedom of choice for mothers and parents. Do you want to have a disabled kid or not? Because there's even more possible in screening. And there is no economic discussion about it.
It's more ethical discussion.
It's an ethical discussion, but sometimes people say it, but when they are against it, they say it's because, they don't want you know, when there's a handicapped kid, you know there's costs. So there is a discussion, if we know more about screening, will there become pressure for the mother not to have the child if you know it's handicapped? And that's a very difficult discussion. So, but it's more an ethical discussion, and some people are afraid it is going to become an economic discussion.
Well, I think what's interesting is where there actually is that very nice marriage between an economic and an ethical imperative. The first 100 days is a perfect example. Economically, it makes perfect sense that you would invest those resources in those first 100 days. That pays itself out for decades, for generations to come.
Maybe to ask to the group regarding the primary care of verloskundige zorg, gynecology. Are there any people, because we're talking about the economic side and the side of the healthcare outcomes, are there any people working around primary care or on the first 100 days of patients? Because I think two hands are raised, because we also have seen, to be honest, that this should go in Dutch very quick, because I don't know all the English words. Dat als de afstemming in de zorg niet genoeg is, dat er moeite was, mede om financiële redenen, om een baby thuis geboren te laten worden of in het ziekenhuis. En dat there has been some initiatives around bundled payment. So to give a bundled payment to either the primary care and the specialist care in the hospitals, to improve the outcomes, because there were these different economic impulses, so to say. I think it's nice to let the people, the two hands who raised, would you like to give your opinion or your
experience?
Yeah, it's funny because I just followed a masterclass by Nick Klazinga, professor at OECD, and right now as a final thesis comparing Finland to the Dutch on this matter, and you see that in Finland the prenatal death is way lower than in the Netherlands, and we looked at what is the cause of the reason, and it's for a big part it's culture, and it is culture just in the is how kids are raised and are being born, but it's also the culture within the hospitals, and it's the way they also the system of the healthcare system around a child being born is organized, and which is way different than in the Netherlands. And so we found out it's much more culture and the way it's organized, and the culture in how specialists work with each other, than it is, for example, you gave the reason that we do home deliveries, but that's not the case. It's achterhaald.
Yes,
I don't know if this is an answer to your question, but
when you say culture, is it culture in the cooperation between the verloskundige and the specialist, or other cultural aspects?
It's both culture. If you look at different cultures within Finland or within the Netherlands, there's a more diversity. So I'm calling immigrants than it is in Finland. So it's culture.
The way that we in Rotterdam we have a lot high birth rate death, and it's also because of from people who are non-Dutch birth.
Not born.
You know what I'm trying to say.
So it's two cultures. It's the culture of immigrants and the diversity there in how they see how kids are delivered, and it's the culture within hospitals or in the care system and how they work together, and especially the overdracht. How that is organized and being done, and that's where I think we can learn a lot from Finland.
And thanks, Wilco, for your experience.
And it's nice because now I'm triggered, because we are trying to make that transfer better with integrated payments, and there is so much resilience against the bundled payments. You know, it's such a big politic issue, and nobody says it's about the money, but or it's about the power, but it of course it's about money and power.
Well, so when we're talking in these early stages,
Yes.
there's some countries that I think are very interesting. And to Karen's point earlier, no country has it perfect. And I don't even think about it as a country having it perfect. It's that there are no easy answers. There are just a lot of really hard questions that as a society and as a group of people who are paying for collectively what those outcomes are, we have to have those discussions. And in the early stages, it's been very interesting to look at Cuba, how they have addressed. So this is a country that has very, very, very poor resources, and what they have recognized is prevention is their key. And so they have some of the best outcomes and some of the very best care. New Zealand is another place where they've invested in the first 1,000 days, their Plunket, because they recognize that investing on that early stage and making sure that moms and babies are connected, that they don't have the postpartum depression. They're seeing the same thing in Sweden. They're doing some programs there. So it's very interesting to see, again, the imperative is we do want to see healthy citizens. We want to give everybody the very best start. We don't want moms to be dying in labor and delivery. And we also know that if we pay for it on the early stage, not only is there a good and a right thing to do, it actually is the smart thing financially to do. So somebody over here also had a comment or an experience.
And please don't hesitate. Continue in Dutch.
Ja.
Praat gewoon lekker in Nederlands
Graag.
als dat makkelijker is. We're trying to be as polite as we can.
You are doing a great job.
But
Yeah.
I thought
No,
people,
you
if
need
it's
to-
hard,
yes.
just do it in Dutch because then we get more into
Absolutely.
the depths.
I'll
of
ask the
answers.
questions, you answer them in Dutch.
Ik sluit aan op waar deze meneer eindigde met de overdracht. We zitten midden in formeren van een integrale geboortezorgorganisatie in de regio Den Bosch. En een van de eerste dingen die we aangepakt hebben is intake in de eerste lijn, oftewel door eerste lijns verloskundigen. Omdat kinderartsen die aan het eind van een hele traject zijn, klaagden dat gynaecologen niet altijd volledig waren in hun eigen intake. Dus zo hebben we eigenlijk twee dingen gelijk getackeld. De verloskundigen hebben meer impact gekregen, oftewel meer inspraak in hoe de zorg georganiseerd wordt. En aan de andere kant krijgen kinderartsen volledige informatie. Daarnaast is ook een MDO georganiseerd waarbij de eerstelijns verloskundigen en gynaecologen aan tafel zitten. Waardoor je aan de kant van overdracht zo min mogelijk verlies krijgt, in de keten in ieder geval. En even kijken, de eerste 1000 dagen traject, oftewel de kartrekkers daarvan, die sluiten bij ons ook aan, omdat je op dit moment alle spelers die daarbij betrokken moeten zijn, al aan tafel hebt. Dus jeugdzorg zit aan tafel, eerste lijn, tweede lijn, de ziekenhuis, gynaecologen, maar ook de kraamzorg. En werd net ook gezegd dat het geen economische prikkel was. Die was wel redelijk aanwezig, omdat in het verleden en eerste lijn en tweede lijn voor dezelfde bevalling beide declareerden.
Precies.
Dus ja, die prikkel was wel degelijk. Het is alleen maar verschil per regio welke zorgverzekeraar de grootste marktaandeel heeft. Bij ons is dat toevallig VGZ. En VGZ is een van de zorgverzekeraars die het niet echt stimuleert om richting integraal geboortezorgtarief te gaan. Vergeleken bijvoorbeeld met Zilveren Kruis Achmea.
Dankjewel voor, je noemde tussendoor namelijk ook nog even in je verhaal de eerste 1000 dagen.
Ja.
Toen dacht ik, 1000 dagen als in het kind van zeg maar min 9 maanden tot 3 jaar? Of wat bedoel je met die 1000 dagen?
De eerste 1000 dagen.
Dus de eerste totdat het kind 3 is, bij wijze van spreken.
Nee, voor de bevalling ook.
Oh, 1000 dagen voor de bevalling?
Nee, niet voor de bevalling. Voor
Sorry,
de
maar
bevalling
laat
daarna.
Of ik heb nog een kopje koffie
Ja,
nodig.
collega gaat aan.
Misschien kan ik een beetje aan...
Conceptie.
Ik ga proberen wat aan te vullen, maar ik heb weinig stem. Ik werk in jeugdzorg en van daaruit zijn die eerste 1000 dagen al jarenlang heel belangrijk.
Dat je heel lang
Maar-
al gezond leeft voordat je überhaupt zwanger wordt.
Nee, niet
hier-
1000 dagen. De
Nou,
eerste
los.
1000 dagen van het leven van een kind zijn voor hechting heel belangrijk. Willen er later niet... je geeft niet... hoewel, als het gaat over, want we zitten op dat brede terrein, waar het bijvoorbeeld ook gaat over armoede of over gelijke kansen, gelijke start, dan zijn de 9 maanden eigenlijk al voor je zwangerschap
Oké, helemaal
minstens
goed.
zo
Heb ik toch
belangrijk
niks
voor een
verkeerds
gelijke
gedaan bij mijn
start van het
tweedochters?
kind.
Hey, nog
Dus-
even terug naar jouw ervaringen met de jeugdzorg. Ook om langzamerhand een beetje tot wat scherpte in de discussie te komen voordat we zo naar de pauze gaan. Wat is jullie ervaring over een stelsel en stimuleert dat hierbij, hè, jeugdzorg wat jij bedoelt, juist die gezinnen waar vaak de multiproblematiek bij elkaar komt. Hoe gaat dat? Kun je daar iets over zeggen, over jouw ervaring?
Een stelsel stimuleert niet. Ik geloof dat dat gewoon standaard gezegd. Een stelsel stimuleert niet. Het zijn de mensen die daar gebruik van maken, die de manieren vinden om binnen een stelsel hun weg te vinden. Ik geloof dat een stelsel heel erg kan belemmeren. En daar kan je tegenaan en daar zoek je de ruimte in. En het zijn de mensen in de organisaties die daar wegen in vinden. En waar het nodig is, moet dat stelsel zo opgerekt worden om daar gebruik van te kunnen maken. Een voorbeeld is onder andere dat de gezondheidszorg en de sociale zorg soms heel ver uit elkaar zijn. Maar een kraamhulp in die eerste dagen heel veel informatie over een kind kan weten te komen. En dat soms moeilijk gedeeld wordt met een centrum voor jeugd en gezin, die juist weer meer die sociale kant oppakt. Daar komt steeds meer en daar zit steeds meer vooruitgang in. Maar dat gaat soms nog langzaam. En in sommige gebieden gaat dat veel beter, in andere minder. Maar het zijn de mensen en de organisaties die vinden dat iets nodig is en dat gaan doen. En daarin kan dus een stelsel heel belemmerend zijn. En daarin zien we steeds weer stelselwisselingen. Maar zo'n stelsel verandert dat niet.
Daarom zitten we hier.
She's
Omdat de
saying
mensen
it's
die
not
dat...
about, she's saying it's not about the system, but it's about the people who work within the system and who are, putting the energy in the right spot to make change. Yes.
Ik denk dat het goed is om ook gewoon op tijd naar de pauze te gaan. We willen graag om 2:15, in tegenstelling tot het programma wat 2 uur zegt, willen we om 2:15 gaan starten. I would like to know if there are, towards Shawna or towards the organization or logistics, are there any questions or things you want to
I was just,
put in the group right now?
yeah, actually, before you do that, I was just going to point out a couple. We talked about cradle to grave, and one of the other really challenging questions around imperatives and economics is end-of-life care. So we did talk a little bit about, so as you're thinking about some of your questions, you might want to go over to that. I mean, the statistics around that, they are very similar across most of the industrialized countries. We spend more on the last days of life than we do in any other point in time. And so the whole concept, what we're working is to live well to the very end, and that we want to compress that morbidity, and so that all of that expense that we spend is just a small amount, but we end well. And I think another statistics that we're seeing or a phenomenon is that too many people are not having a good experience. They're not dying in a way that they want to die. And what I mean by that is who they're surrounded by, the location, are they prepared for it? Do they have an emotional experience? Are the care providers? There's so many pieces around that. And what we know is that it's a difficult conversation. So again, it's an imperative, and there's an economic driver around that. So as we think about the beginning of life and the end of life, and then there's all of that other stuff in between, but those are two really good areas to focus on, and they're not conversations that we have very well.